Hello, this is Daisuke Suzuki, PhD from Chitose College Rehabilitation, Japan. Background: hip instability is one of the symptoms of patients with developmental dysplasia of the hip, DDH. Our research group reported that femoral head of DDH patients shifts anteriorly during hip external rotation by performing 2D 3D matching of false profile X-ray images and 3D CT images. DDH patients often have anterior pelvic inclination. The aim of this study is to evaluate the relationship between pelvic anterior inclination and femoral anterior translation in DDH patients using the finite element method. Patient and methods. Preoperative CT image of a female patient who underwent rotational acetabular osteotomy at Sapporo Medical University Hospital were used. Her tension grade was 0. First, 3D software was used to construct the CT image in 3D. From the 3D constructed images, 3D image software was used to separate the coxal bone and femur, and the labrum cartilage complex and auricular surface were created. Finite element analysis was performed using mechanical find version 13 based on these 3 CT images and the 3D constructed model. 4 finite element models were created. The base model was modeled in the same position as the CT scan. This was set to 0 degrees external rotation and 0 degrees pelvic inclination. From this base model, there was a model with 17 external rotation and 0 degrees pelvic inclination, false profile 0, a model with 17 external rotation and 5 degrees pelvic inclination, false profile plus 5, and model with 17 degrees external rotation and 10 degrees pelvic inclination, false profile plus 10. The external rotation angle 17 was selected because in patients with DDH, the average hip external rotation angle take first profile X-ray was 17 degrees. Furthermore, to simulate hip joint instability, a plus 1 mm model was created by shifting the femoral head 1 mm anteriorly from each of the 4 models. In fact, an average anterior displacement of 1 mm is observed in the first profile view of patients with DDH. Boundary conditions for the finite element model. For each model, displacement of the x, theta y, and theta z direction was constrained at the auricular surface and pubic symphysis. The distal femur was fully constrained. To ensure that pelvic inclination remained unchanged, the load boundary conditions were applied to each part of shown in the figure. The following items were evaluated in the finite element analysis. In the 4 models, the anterior displacement of the femoral head and the contact pressure of the femoral head. In the plus 1 mm models, the change in the pelvic posture. Here are the results. First, for the load boundary conditions, the direction of the axial load on the upper body was changed, so that pelvic inclination did not change each model. The greater the pelvic anterior inclined, the further anterior the load of the upper body moves. On the other hand, all other load conditions were unchanged. This is the displacement of the femoral head. The direction of displacement at each node point of the femoral head is expressed as a vector. Compared to the base model, the false profile 0 model, which has an external rotation of the femur, has increased amount of femoral head displacement. Also, as anterior inclination of the pelvis increases, the femoral displaced from anterolateral to lateral. In other words, the amount of anterior displacement has decreased. This is the change in contact pressure on the femur. The greater the anterior inclination of the pelvis, the greater the maximum contact pressure. On the other hand, the average contact pressure barely changed. When the same loading conditions were applied to the 4 plus 1 mm models, the base model plus 1 mm showed a 10-degree posterior inclination of the pelvis, and the false profile 0 plus 1 mm model showed 12 degrees posterior inclination. However, changes in pelvic inclination were minimal in both the false profile plus 5 plus 1 mm model and the false profile plus 10 plus 1 mm model. Discussion. In this study, we created the finite element model based on the DDH patient and evaluated the pelvic inclination, anterior translation of the femur, contact pressure, and pelvic posture. The amount of anterior translation was greater during external rotated position. It suggests patients with DDH are unstable at an external rotated position. As pelvic inclination increases, the femoral head shifts anterolaterally to laterally. However, the amount of translation itself does not change significantly. It suggests the amount of anterior translation decreases. As the pelvic inclination increases, the maximum value of femoral contact pressure increases, but the average value does not change significantly. When the femoral head shifts anteriorly, the anterior inclination models were stable. It suggests if the pelvis is inclined anteriorly beforehand, less muscle force is required to stabilize the pelvis when the hip joint becomes unstable. Conclusion. The anterior pelvic inclination during standing and walking seen in DDH patients suggests the maximum contact pressure on the femoral head is increased. However, it reduces the anterior displacement of the femoral head, stabilizing the pelvic posture.